I have a question that is sort of a higher altitude question to step back a little bit from getting into the weeds about treatment. For almost everybody in this room that has been diagnosed with multiple myeloma, I think I speak for a lot of patients, and I'm also a patient and a caregiver, but if any of you had to recommend to primary care physicians a screening, and at what age would you recommend what type of screening for a patient that's been in their practice to try to flush out patients who may end up developing multiple myeloma? Again, understanding it's a small subset of cancers, but I think everybody that I've talked to, my wife has talked to since she's been diagnosed, these diagnoses come about by accident, and they don't come about by clinical testing. So is there something you might recommend to primary care physicians or, say, orthopedic surgeons when somebody comes to them with joint pain, bone pain, to just kind of try to flush out, maybe we're missing something here?
Okay, so there's kind of two things I want to say around that one. The first one is about general screening in the population. We're all eagerly awaiting results from a big study in Iceland. Iceland is quite an unusual country in the fact that it doesn't have a lot of immigration or emigration. And so it's quite easy to study those patients, and they have a uniform health system. And so what they're doing at the moment is actually screening the whole population for the presence of MGUS and smoldering myeloma, so those early diseases. And if they find that if they find people who have got it, they've then got a study looking at what happens if you let the patient know, what happens if you don't really say anything, and also what happens if you let the patient know and then do some intervention. The idea being is if we start screening everybody up front, well, what will the implications be? Okay, because you can imagine, and I don't know if we have any MGUS patients in the room. Okay, yes, it's kind of good to know, but it also has a huge psychological part to it as well, because potentially there's, at the moment, as far as we're aware, not a lot we can do about it. Hervé's work is clearly changing the field in that. But so there's all of that study going on, and we're really looking forward to seeing all of those results, because I think it's got huge kind of implications for practice. So that's one side. The other side is exactly as you say. I think generally we have a big educational role we need to play for our orthopedic colleagues, our renal colleagues, and our PCP, so our general practitioners, about what they should look out for and when there should be like a light bulb moment of, oh my goodness, I need to look for myeloma, okay? And so to some extent people do that, so they will often run an SPEP and a serum-free light chain assay, and that should hopefully happen at a minimum, but we're really trying to get people to do that much more routinely and not leave it until patients have obviously got a lot of problems.
Okay, other questions? I know, but maybe I'm not, right? I guess to follow up on that question, I get all these ads. I listen to sports radio, so I get a lot of ads for the Princeton Longevity Center. And it's not about them in particular, but right, like that, it's like these places that offer, like, oh, you can come in and we're gonna spend this whole day doing tests and like all this stuff, we're gonna get you all this information. So if like I wanted to go somewhere, obviously my insurance won't cover it, but like pay out of pocket to get like whatever they're doing in Iceland, is that something that's actually available today? Or I'd have to go to Iceland and they wouldn't let me in?
What they're doing in Iceland is mainly just screening for myeloma and MGUS. So it's just a blood test, and potentially some patients need a bone marrow, but that's looking not for all cancers or other things, just for myeloma and MGUS. So that if there is a risk factor, a reason that you, or symptoms that you need it done, then your doctor can do it in any place. You don't have to go to a specific place for that.
Okay, so it's something that's like.
It's the same test that's done for myeloma, but we don't recommend that all family members get screened for it, but it's the same test that you would do for myeloma. But it's just that unless there's some clear high-risk reasons why.
Yeah. So I want to elaborate. I want to elaborate a little bit more on that Iceland study. The way that they were testing the blood, thank you, testing the blood for patients, looking at protein abnormalities with a very sensitive assay called mass spectrometry that can detect a lot of noise as well. And what they found out, what they've reported on so far is 4 to 5 of, it's not me, it's all almost in my mouth now. So the mass spectrometry detect 4 to 5 out of 100 people might have some funny protein abnormality. If we start doing that test on everyone, we'll get a lot of noise. And we know that majority of patients who even have MGUS will never develop or any other problem. There's a problem with this microphone, and we need to really replace it. So that's the issue, you know. So I want to reiterate what Dr. Davies said, that even if you find out that there is a funny protein in the blood, you may not develop a problem for the rest of your life. But do you really want to know that ahead of time, right? So that's the other piece. What is the return on that investment? Is it going to just continue to give me anxiety for the next 30 years, and you know, I get something else that will you know, lead to my demise in life, or do I you know, just see how this goes? I think that the other piece is, once we prove that if you have A, B, and C features, yes, you should be screened. That information we don't have from the iStop-MM study yet. So once we have that, yes, screening would make sense. But for majority of patients, you know, what they're seeing right now is it's not leading to any intervention.
Okay, we have a question right here. What do you recommend for imaging follow-up for monitoring, the MRI or the CT?
Which setting are you talking about? Is it MGUS, active myeloma? Or it depends. So for smoldering myeloma, what we're really looking for is changes in the bone marrow, and an MRI is preferred because you can see the changes of myeloma cells starting to quote-unquote congregate, or what we call myeloma focal lesions, before the bone damage occurs, and you see it best on an MRI. But for my patients who have intermediate or high-risk smoldering, I try to alternate a PET scan with an MRI off and on to make sure I'm not missing anything.
If we do develop some kind of cure soon, whether that's a specific cure or a combination of therapies, are we going to be able to know that we've found the cure? Or do we have to then wait 10, 15 years and then, okay, if everyone who got this no longer has it, then we can say we have a cure? Or is there some other way we can figure out?
Yeah, so the only way that we can say something is cured is with the passage of time. And that's true for everything. So the only way that we can say that we cured testicular cancer with 3-drug combination chemotherapy is because we followed those patients for the next 4 decades and did not see the cancer coming back. The issue with myeloma is that most patients develop it later in life, and there are competing risks for death. It could be the heart, it could be the lungs, it could be something else. The proposition is different for someone who's young like you, because you have ways to go. But it's really a function of time. The way that and this is where what functional cure definition comes into play. So if someone does not want me to say what I want to say, okay, all right, just kidding. So so if you're diagnosed in your late 60s or early 70s and you have other health problems, if you get to MRD negativity and you're off of treatment and for the next 5 years you're MRD negative, I'm very comfortable saying to that patient that you're functionally cured. Just continue to take other treatments, but that's just me. What we've seen in studies is people who continue to have sustained MRD negativity, they're the ones who continue to drive that progression-free and overall survival curves in clinical trials and in other data sets that institutions like Emory and the Spanish Myeloma Group publish. So it's really, that's my internal, definition of functional curability.
So
Long answer.
that's why the meeting we had with the FDA recently was so very important, because from their perspective, to bring a new drug into myeloma, they always wanted to see that we were improving patient survival. And exactly as you say, if that was our endpoint, we were never going to get any new drugs in myeloma because we'd be waiting so long to be able to prove that. And so the test that Dr. Osmani is talking about, that MRD test, convincing the FDA that we could use that as a surrogate, that we could say, if patients get this incredible response, we believe that translates into an improvement in survival, was a huge step, because now hopefully it will speed up the development of all the new drugs and bring them into the clinic much quicker as well.
I spoke with a woman, I think last year, at one of these conferences, and her 17-year-old daughter had this disease. How common is it for a young person to get it?
Yeah, so the number of, someone asked me the same question, during the newly diagnosed, session as well. If we look at the incidence and prevalence of multiple myeloma, active myeloma, on a national level, the proportion of patients who are under the age of 50 has not changed in the last 5 decades. However, because we are centers of excellence and see a lot of myeloma, we actually do see a lot of young myeloma patients. And I've seen some patients in their mid to late teens as well, but it's not very common in that, for patients that young to have it.
17 would be very low, very young age, unusual. 20s and 30s, there are a handful of patients, I would say. 50 and above is typically the majority of patients, but certainly in large volume centers, you see people younger than 50. 17, I would say, would be one of the youngest ages you could see myeloma in, and exceedingly uncommon.
First of all, thank you very much for this excellent presentation. I have 2 questions. First, maybe it's simplistic, but is there a consensus on the cause of myeloma in developing and what causes the cells to go crazy?
So I think there are multiple factors. Unfortunately, myeloma is not simple where we can say this one thing causes myeloma. But we know there are many environmental factors, lifestyle factors, genetic factors that may be playing into it. So when we think about environmental factors, we have seen that in 9/11, people who were exposed to the World Trade Center dust have a higher risk. Firefighters have a higher risk. Agent Orange exposure has a higher risk. Some chemical and other things can also have a higher risk. So that is their occupational related. then those are environmental factors. When we talk about lifestyle factors, we talked about in my talk was about how obesity, diabetes, diet may also play a role into it. And then the last would be genetic factors, where there is some clustering in family members, where somebody might have a parent or a uncle or aunt or sibling who's had myeloma, and then they're at a slightly higher risk for that. But that clustering is such that it's not where we can say to you that because you have a family member, we should test everybody in the family for it, because there's not one clear gene that we could say is hereditary, like in breast cancer, where we might say, if you have the BRCA gene, you are going to have a higher risk. We do something about it. So unfortunately, there's not one thing we can target and to say for each person, this is what caused your myeloma, and it's, I think, a comprehensive
Okay,
thing.
thank you. And the second question is, I'm 4 months post stem cell transplant. Thank God I'm in remission. Is there one, besides the possibility of it recurring, is there a type of cancer that most likely does reoccur separate and apart from the multiple myeloma, for example, lung cancer or stomach cancer, or is there one particular type of cancer that usually comes back or starts to develop?
So just to clarify, your question is not the risk of recurrence of myeloma, but the risk of developing other cancers
Yes,
as a
whether
consequence of having myeloma and its treatments.
Exactly.
There is an increased risk. I think one of the challenges is that, as we discussed in the previous question, myeloma is typically seen in older adults, people over the age of 50 years. And cancers in general tend to increase in incidence as we grow older. So there's a natural history to developing cancers that, with some exceptions, generally many types of cancers are more common with older adults. So just as a function of aging and living longer, we unfortunately will see patients being diagnosed with other cancers apart from their primary cancer. That said, there is definitely, we think, an increased risk from the diagnosis of multiple myeloma and its treatments. Some studies have suggested that there's disease characteristics itself that might increase the risk of other cancers. And then there's increased risk from specific drugs we use for the treatment of multiple myeloma. For instance, the transplant, which is a very effective myeloma treatment and one that many patients can and should get, does increase the risk of other cancers to a small degree. Lenalidomide, another highly effective treatment commonly used, when used as maintenance for an extended period of time, can increase the risk slightly higher. We still do both of these treatments quite commonly because those risks are small, and the risk of the myeloma coming back and causing more problems is much higher than the risk of developing secondary cancers. In terms of what kinds of cancers, there's reports of multiple kinds of cancers being diagnosed after treatments. The ones that statistically seem more significant are other blood cancers, leukemia, myelodysplastic syndromes, acute lymphoblastic leukemia, for instance. There's also some data that non-melanoma skin cancer, like basal cell carcinoma or squamous cell carcinomas, are somewhat increased. For all the other kinds of cancers, we don't have high enough numbers to say that they're statistically more common than in patients who are otherwise of the same age and general health.
I have a question about MRD negativity. Does it matter when you achieve it in terms of the disease?
I alluded to this earlier in my presentation. It depends on the kind of myeloma you have. We're just learning about this. There are patients who may achieve MRD negativity 2 years into their treatment, and that is totally fine. It's just because their disease was more indolent and had a more, slower response, but they can get to MRD negativity after 2 years, and that's totally cool. There are other patients who are going to get to that endpoint faster. So it's dependent on the kind of myeloma you have, and it's not an easy answer. So I don't know the specifics about your myeloma, et cetera, if that's where the question is coming from.
Just in general. I mean, it's like if you're 50 and you just keep getting treated till you get there, or you just do some other treatment. I mean, I'm 75. I'm almost there. I mean, going to just continue on that? So is there a difference of?
Yeah, just continue what you're on,
Or
yeah.
It's worth getting to regardless of where you are. I guess is my
So,
question.
I mean, so this is, I want to make sure that you were paying attention to that slide that I shared with you, because it looks like you were not.
Yeah, I guess not.
Yeah, so my talk began by telling you that a third of the patients, even if we give 4 drugs as induction, if we give a transplant, if we give 2-drug maintenance, even after all of that for over 3 years, a third of the patients don't get to MRD negativity at 10 to the minus 6. And there are many of those patients who still do fine, okay? So what I'm trying to tell you is not every patient is going to get to MRD negativity. Some will get there in, after 1 year, some will get there after 2 years, some will get there after 3 years, and many, a third of them who went on these trials didn't even get to MRD negativity. We have many of those patients in our practices, and they do fine, there is no way we are getting 100% of our patients to MRD negativity now, but that will be the aspirational goal for us. And if you're not transplant eligible, only half of the patients are getting to MRD negativity, and even a smaller proportion who are maintaining that MRD negativity. So MRD is an aspirational goal for us. If patients get there, that's great. It will be, excellent for their survival outcomes. But patients who don't get to MRD negativity don't necessarily have a poor outcome. They can continue to do very well for many, many years. So, I don't want the message here to be that, just throw everything that you can at myeloma to get to MRD negativity. That's not what we've talked about, and eventually we'll get to 100% MRD negativity for all our patients, and we'll cure this, but we're not there yet.
Yes, hi. Along those lines, what do you know about the new test out, EasyM, I believe it's called, for getting to MRD negativity?
Is that the mass spec one?
Pardon?
Is it?
I've been getting...
Sorry, we're just having a discussion over.
okay. It's a blood test that's supposedly non-invasive and replace BMD.
Okay, so there's a number of ways of measuring a patient's response to therapy. And we've heard about the bone marrow ways, but there's also a number of new sensitive ways we can do it from the blood, okay? And these are based on various technologies called a mass spectrometer. Okay, and this is one of the ways. And I think they're going to be incredibly helpful, is the truth be known, because they're going to give us a deep reading without patients needing to have the bone marrow test. We may still need to do the bone marrow test intermittently because it gives us some additional information. But you're completely correct. Having a blood test to help us to do this is going to be great. And one of the things that's kind of happening moving forward is that within many of the clinical trials, they're being incorporated this mass spectrometry technology so that we can really learn how to use it properly, and we can learn a little bit about what we tell patients if we get a positive answer or if we get a negative answer. So we're kind of, it looks as if it's good, but we just need to kind of do that fine-tuning so we know exactly how to use it wisely.
Hello? I don't think it's working.
It's okay, you got my microphone.
One of my side effects is cramping, and I have a cramp right now. Thank you, all of you. It's a bad one. My question is, see if I can do that while cramping, is when you get to MRD negativity, is it automatic that you're taken off treatment? And second, what does the number actually, I know it's 1 in a million for the blood test, but for the M spike, is that like any number less than 1, like 0.1? It has to be below 0? Non-detectable at all?
It has to be the MRD test. When you look at serum protein electrophoresis, that M spike should say 0. The immunofixation should say no monoclonal protein detected. And then the blood, the bone marrow biopsy should say no abnormal cells found by flow if it's a flow test. If it's a next generation sequencing test, it should say no abnormal sequences are found. So that, and by immunohistochemistry, also another way that the bone marrow looks, it should not find any myeloma. So there are a lot of different things that have to be met to call that an MRD negative myeloma, and the PET scan should be clear too. In terms of the maintenance discontinuation question, there are studies going on. So our colleagues at MSK, Dr. Corday, is leading a study looking at patients who are MRD negative for a few years. There was also a study from University of Chicago looking at this. So overall, like if patients are long-term MRD negative, can we stop maintenance therapy and how do they do? And then there are other larger phase 3 studies also looking at this. While the data is early, it looks encouraging, but it's not yet ready for us to tell every patient and tell you at this time we should stop. But I think we're getting there, and soon we'll have a subset where we can tell you this is where we can stop.
Are you okay, sir?
I'll be okay. It's just a cramp I've had worse.
Hi, Dr. Shah, I was wondering, is there a place where we can get a menu or a list of foods, or perhaps the foods that you were giving to people in your studies for the nutrition, to find out if it's something we can replicate at home? And then also your opinions on supplements. I must get 100 emails a day of all the different kinds of vitamins and supplements that you should be taking for health. And I was wondering if there's something that you recommend. And then also, should you also talk to your doctor about this for possible interactions with, maintenance meds or any kind of medicine that you're on?
Great question. So the supplement part, definitely if you're on drugs for your chemotherapy and you're starting to take supplements, discuss it with your doctor, because if there are interactions, it could lead to more toxicity. I think in general, most studies that have looked at supplements have unfortunately been negative in terms of the outcome. And part of it is because when you do a drug study, all the people in the control arm never had the drug compared to the people in the intervention arm have the drug. When you do a supplement study or a diet study, the people in the control arm are still eating and they're still getting some of these minerals or things. So their control arm is not true control as the control would be for a drug study in some ways. So that kind of makes the effect size, or it's a little harder to study. But that being said, we have to look at these studies and say, is it benefiting? And most of the studies have been negative. However, it depends, I think that, so in general, also like the American Institute of Cancer Research doesn't recommend supplements to treat cancer or for cancer overall, because studies haven't shown that. And even things like vitamin B6 have sometimes shown increased cancer risk, not decreased, for lung cancer or things like that in large populations. So I don't think all supplements, just because it's natural, it is benign, because it is coming, even drugs like chemotherapy sometimes are coming from plants or herbs. It's just the dose that makes the drug toxic versus, not. So we have to think about all those things. In that context, I think supplements have a role for certain things and certain situations. So for instance, if somebody clearly has iron deficiency or clearly B12 or B6 or something like that, then that supplement would help them. Other supplements like curcumin, for instance, a lot of patients take in myeloma. I think that there is side effects related to, like drug interactions could be a thing with that, because it inhibits enzymes, so we have to be a little careful, and maybe slight increased bleeding risk. But beyond that, some patients might benefit in terms of pain, like it is supposed to be good for anti-inflammatory arthritis, things like that, so some people see that benefit. And in terms of smoldering, there is one trial that was done that maybe showed some signal of change, but it's not enough to tell our patients to do it. But because of that, we're doing a study looking at that supplement to understand its effects and see what's it doing to the microbiome and what's it doing to the overall health. So after that, we might be able to guide and say like whether it's worth it or not. I think supplements are very expensive. One thing is that we're doing a study with HealthTree looking at patients for supplements, and we've surveyed over, I think, 400 or so patients. We're putting that data together and should be publishing it soon on patients' experience, the cost, and things like that with supplements.
So that in itself, I think it has to individualize. Recently, MSK put out an article on magnesium in supplements. So that if you want, you can Google MSK, and then if you put my name, I think you'll find it. And last thing, your question was around information. American Institute of Cancer Research is a very good place where there's a lot of information. And I try to post a little bit. You can look up Urvisha MD and you would find that. But I think it's a bit hard to otherwise clearly.
I was just going to say, if you look at that article on magnesium, actually, you'll get a recipe from Dr. Shah herself. It's a nice recipe for overnight oats for breakfast.
That's true.
Hi. Hi, thank you so much. It's not really a question, it's just to say thank you to HealthTree Foundation for putting this together and for the panel. I think they're interesting enough, and being in a room with so many amazing people, from the patients to the caregiver, it just feels so good. And also, it makes me look forward to a healthy life, living with myeloma and in a good mental health state. And then also, it gives me an opportunity to have some questions for when I do see my doctor, to really have a personal conversation. I feel so powered, and I'm excited for my appointment coming up because I know it's going to be an interesting conversation. So thank you.
Just while we're getting the other question there, I just want to thank you guys for coming. It's been amazing for us to meet you all. And I was just saying, from my perspective, it's great to see people talking to each other about their myeloma and about their experiences, and to learn from people. You know, we've got 11-year survivors here, longer, and I think it's important that we learn from them, as well as we've got people who've had similar side effects from their drugs, so being able to compare notes. So I think it's great. So well done, you guys, for coming, and thank you for coming.
I have two questions. One is for Dr. Shah. Does she think that a stool sample should be part of the normal intake process for patients in the future to try to look at the microbiome? Because it's something that most of us have never actually analyzed and looked at that. And then the second one is on the drug Dex. What's the purpose really of that in the cocktail? And do you envision any changing on the dosage of Dex in the future?
So your question about the microbiome, I think that's the good foresight, and I think in the future that is somewhere where we all like to see microbiome research go. While we do blood tests, we do bone marrow tests, we should be looking at the stool too. And just now, most of the tests are all research-based because there is no validated test that we could run and say, like, this is a clinically approved test to make decisions based on. So unfortunately, it's all research-based now, but I think in the next years, we are going to see more of like a clear test where we could actually act on and say, like, we get a quick turnaround. So hopefully soon.
For the DEX question, I guess I think the question was, why do we use DEX? Or if can we lower the dose, and do we need it anymore? I guess few pieces of info answers, I guess. Number one is, I think part of the reason we use DEX is historical. Dexamethasone was one of the first drugs to have any level of activity in multiple myeloma back in the 50s and 60s. So as such, anytime, and for a very long time, we did not have any other new drugs, or very few new drugs. So it's convention to any new drug, you were trying to add some dexamethasone because you knew the dexamethasone was working. And so that's how DEX came to be added to all treatments. That's obviously changed in the last 25 years when we have many drugs, but that history of adding dexamethasone has continued on. One of the most important trials in multiple myeloma was probably actually something that a patient like yourself suggested some years back, about 15 years back. The convention was actually to give patients 160 milligrams of dexamethasone a week. That's about more than 4 times the dose that many of our patients today get. And it was a patient who encouraged the researchers in the ECOG, Eastern Cooperative Oncology Group, to do a study that was specifically focused on looking high-dose dexamethasone versus what they considered as low-dose dexamethasone, which today would still be considered as pretty high, that is 40 milligrams of dexamethasone. And that study pretty convincingly showed that you don't need 160 milligrams to get the efficacy, and you actually, as expected, see a lot of toxicities. Since then, the challenge with doing trials with lower doses of dexamethasone is that there's so much excitement for these other drugs and treatments that there's limited interest, I guess, to do an exclusive study so focus solely on lowering the dose of dex further. That said, all of us in our practice would feel pretty comfortable lowering the dose of dex as patients respond and potentially stop dexamethasone altogether eventually, with the idea of limiting the total amount of dexamethasone exposure.
So, I want to take a moment and actually give a shout out. It was Michael Katz, who is no longer with us, but, he was an amazing patient advocate, and, we've done a lot of things in the field as physicians, but I think having this partnership and the fact that you had a patient advocating for this and actually led to improved outcomes was phenomenal. And Michael was an amazing patient advocate. I still remember meeting him for the first time and as junior faculty, and he knew more about myeloma than I did. And that was very humbling. And yeah, so this. What we're doing right now works both ways. So, and that's the big lesson we learned from him. That this is a partnership. We're all in this together. So we learn from you guys more than you learn from us. This is, and so, be open about your comments to us because we are listening. And we do think about these things when we go back and think about designing clinical trials.
Last one. So the website for the EZM mass spec test says that it's, I think, 100 times more sensitive for the M protein than SPEP. Are there some people out there that could be called non-secretory because they have a negative SPEP, yet could they have a tiny amount on EZM?
Yes, completely correct. So you're right. Before we had the serum-free light chains, we would categorize people as being non-secretors. Then we got the serum-free light chain test, and that made those patients to become secretors. And you're completely correct. With these mass spectrometry tools, we're now finding that patients who were previously known as non-secretors actually do have evidence of a protein there. So yes, correct.
Okay, well, I think what you just shared is this, what I want to just follow up on is this partnership. So let's give them an incredible round of applause.